Teddy Mosomotane,
swear that the evidence that I shall give
swear that the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth.
the whole truth,
Raise your right hand and say, so help me God.
so help me God.
Thank you. Ms. Musia, are you going to take the oath or the affirmation?
I'll take the oath, Chair.
Thank you. And will you say after me, I and your name,
I, Lerato Musia,
swear that the evidence that I shall give
swear that the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth.
the whole truth,
Raise your right hand and say, so help me God.
so help me God.
Thank you. Mr. Paleng,
Yes, Chair.
will you take the oath or the affirmation?
Yes, I will.
Yes. So will you say after me, I and your name,
I, Tebogo Paleng,
swear that the evidence that I shall give
swear that the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and raise your right hand and say, so help me God.
so help me God.
Now, Ms. Richards, did you say you're from ENS? Yes. All right, so I don't want to get lawyers taking oaths. What's your role? Are you going to be making any submissions or?
Only just in support of Teddy if he requires it.
All right, no, that's fine. Then I will skip you. And then that takes me to Mr. Mosiane. Will you be speaking?
Yes, I might assist.
You might assist. Okay,
Yep.
so let me take your oath. Will you then say after me, I and your name,
I, Bruce Musiani,
swear that the evidence
swear that the
that I
evidence
shall give
that I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and raise your right hand and say, so help me God.
so help me God.
Thank you. Mr. Mosomotane, let's start with you. You said that you had a presentation. I see that's already up on the slides. Is that the one?
That's the one.
All right, thank you very much. So you take us through and then you can decide how you want to structure it.
Okay, thank you very much, Chair. First and foremost, on behalf of the Health Funders Association, we want to express our appreciation for the opportunity that we have been given to participate in this process. It's probably fair to say that the core issue that is being investigated doesn't fill one with excitement necessarily, but it demands attention, and we are certainly happy to oblige. I think I also have to mention, observe the discussions over the last couple of days. We observed with appreciation that, given the complexity of the many issues that we deal with in the healthcare industry, there's always a temptation to really raise a variety of issues that we are faced with over and above the core issue, that the panel is entrusted to focus on. But be that as it may, our observation is certainly with understanding as far as that is concerned, and we are committed to make our contribution as best as we possibly can. Now, in as far as HFA is concerned, HFA is made up of members in the form of entities, which includes medical schemes, administrators, and managed care organizations. HFA really goes as far back as 2015, and right now in our membership base we have a total of 25 medical schemes, and this is made up of 8 open schemes in particular and 17 restricted medical schemes. So in as far as the membership representation within HFA, we are talking 53% in as far as beneficiaries that are associated with the medical schemes in these entities. And I'll give you a sense of which entities are included in our membership base in a minute. From a number of lives perspective, Chair, we are talking 4.4 million lives, and I've already indicated that there's 25 medical schemes and there's 3 administrators. Just to give the panel a sense of which entities are included in our membership base, I certainly don't intend to go through each and every one of them, except to say our membership base certainly comes from a diverse industry, and this is inclusive of a number of administrators that make up our membership base. At this point, Chair, I want to really proceed with telling the panel a couple of things about HFA, to introduce HFA so that they can be understanding of who we are. In as far as our role is concerned, we see our role as focusing on facilitating and encouraging the establishment of a conducive healthcare funding industry. And this we want to pursue through active engagement with all relevant stakeholders. And it is important to know that it is our desire to have these engagements with parties both in the public and the private sector. We also attach a lot of importance to sustainability and development of private healthcare funders, in particular. This is against the background of medical schemes not being expected to be for-profit organizations, but entrusted with the responsibility of giving assurance in as far as sustainability is concerned. We are committed to participating in conversations that are aimed at influencing policy and legislation reforms going forward. In the course of the conversations that are taking place in the industry, Chair, it's important for us as different stakeholders to be engaged, and this is where HFA comes in to cater for a need of advocacy and lobbying, creating an opportunity for us to present a united voice of the members of the association. As far as the structure is concerned, our structure is relatively lean and made up of a board of directors that comes from our membership base. We also make use of what we refer to as a technical advisory committee. This is where Bruce Misiane, comes in. And the purpose of that kind of a committee is to deal with the details in relation to, all aspects that require attention and conversation, in the industry that we're operating in, and feed those kind of discussions into the board for a decision in as far as how we navigate our way forward. From a values perspective, we attach a lot of importance to collaboration and cooperation. We are passionate about adding value in our association and the partnerships that we have with our stakeholders. Driving competitiveness for prosperity is something that we attach a lot of importance to, and we also embrace, diversity as best as we possibly can. Chair, over the last couple of years, going as far back as 2015, we have prioritized engagements on industry matters. We have done this through a variety of ways, really aimed at ensuring that we are contributing in the conversations that are unfolding in relation to the changing healthcare landscape. Examples of this is by way of having ongoing interactions with the Council for Medical Schemes as our regulator. We think it is important to nurture some kind of a relationship with the regulator, understanding that that kind of interaction will sometimes be accompanied by the inherent kind of tension where there are different perspectives that are expressed. In this regard, we are very appreciative of the Council for Medical Scheme being very keen to have conversations with the different stakeholders on a variety of matters. Examples in this regard include the Fraud, Waste and Abuse Summit that was hosted by the Council for Medical Scheme, which is quite relevant to the matter that we are talking about today. There's a range of other discussions that are underway in the industry, and the PMB review is but one other example. We have deliberately decided not to list all those conversations that are taking place. Now, our engagements have also included our participation in what was referred to as the Presidential Health Summit. what became known as a compact that came out of those conversations was signed last week. And our participation there, again, was aimed at ensuring that we make a contribution to the conversations that have taken place. Our involvement in the Presidential Health Summit in particular, Chair, was via our association with Business Unity South Africa, where there are other ongoing engagements that are taking place there, including NHI-related engagements, wherein entities like NEDLEC play a role. So this gives, a sense of a range of activities that certainly keep us busy. Now, Chair, coming closer to the main issue that has really brought us together, today. Here I'm talking about the Section 59 in investigation. We acknowledge the terms of reference that emerged, towards what the panel is mandated to do, and I'm not going to go through them in any, detail because, the panel and the audience will certainly be aware of this. What I do want to say is that HFA, as an association, is not directly involved with the scheme's operational activities relating to fraud, waste, and abuse, because we are certainly a different entity. We are an association. We interact with medical schemes and administrators, but we are not, involved in the operational activities in how they respond to fraud, waste, and abuse. It is also fair that we certainly condemn all forms of bullying, racial profiling, and unfair treatment that has triggered this investigation. Now, having said that, at times it's possible for one, when you say that and stop there, to come across as if you are, confirming that these practices are indeed taking place in the industry. Now, our interactions with the medical schemes and administrators suggest that partly because of the fact that there is no data that is collected as far as race is concerned, and an argument is made that it would be impossible to racially profile practitioners in particular, which is what is relevant in the specific case. So we find the arguments that are being made quite plausible, but we also do not want to be dismissive of the allegations that have been raised, and we have resolved that we are certainly going to trust the process and see what comes out of it, and participate in the process in good faith, and take appropriate action, at the end of the process.
Can you just tell me, what is the explanation that you are getting from the schemes? So the one explanation is that we don't collect racially aggregated data.
Yes.
So what is the other explanation? Because, to say we don't collect the data doesn't mean there's no racial profiling. Because one of the problems is that we've now sat here for day number 5 today. We've had medical associations, doctors, practitioners across. What they show, one of the presenters showed us that the blacklisted practitioners from GEMS, it's almost 98% black. Discovery says, well, we don't have the statistics. And I asked the same question yesterday to another presenter, to say, well, who are the doctors that are being blacklisted? Who are the target of Section 59? Are they black or white? And then they say, no, from our experience, it's overwhelmingly black. So what is your own experience?
Chair, the reality is, amongst the responses that we receive is, include the fact that we do not know, why the outcome looks the way it does.
No, but what does the outcome look like?
Well, based on what has been, advanced in as far as these allegations are concerned, that is the outcome, that I'm referring to. So the allegations are suggesting that there is racial profiling, and the response is that we don't know why that is the case. It's partly for that reason that we are committed to this process and are trusting of it to see, what will come out of it. Amongst the issues that were raised, Chair, in the course of our conversations over the last a couple of days, was the concept of social solidarity. Now, there's a lot that has been raised, and I'm just touching on this one in particular, because we think it is important to provide a perspective from where we are sitting in as far as this amongst a number of elements that have been raised. What we want to bring across is the fact that we believe the fundamentals of social solidarity, first, are fundamentals that we embrace from an HFA perspective to the extent that they are supportive of, intentions to have good quality healthcare accessible to as many citizens and beneficiaries as possible. Our observations are that the environment that we are operating in now, with reference to the Medical Schemes Act in particular, certainly includes these fundamentals relating to social solidarity. And these include open enrollment, and the fact that contributions, from a contribution perspective, now it's important for one to make the point in this regard that contributions from a medical scheme perspective is the primary source of income if one excludes investment income that may be generated if the medical scheme managed to generate some savings. So there's an aspect of community rating in as far as contributions are concerned. And now, community rating really entails the fact that from a contribution perspective, it doesn't matter whether one is young or old or has a different risk profile from a health perspective. Everybody is treated the same. There's income rating is allowed, and I should explain this by indicating that the Act as it is now would allow medical schemes to use income bands to cater for those with low income, and while they also still have healthcare needs as everybody else would. There's also no clinical risk rating, and in addition to that, Chair, there is what we refer to as prescribed minimum benefits, which are really guaranteed risk benefits. And we see all these as elements of social solidarity which are incorporated in the healthcare environment that we are operating in. And we think it's important to express this perspective so that we cannot come out of this episode with an understanding that this is something that does not exist. It is also fair to say, though, that even though these fundamentals and elements may be there, they may very well not be generating the desired outcome or impact, and we all have work to do as far as that is concerned. But the point that I want to make, these elements relating to social solidarity, are certainly there. Now, there are challenges that we find ourselves having to attend to in the healthcare, environment, and these include the deterioration in as far as the risk profile is concerned. And we would argue that there's definitely risk pooling, as well. And this can sometimes be across the different benefit options that a medical scheme would offer. But, the optimization of the risk pool makes it a lot more possible for us to achieve affordability considerations to the extent that we possibly can, taking into account the healthcare needs of the individuals that belong to these medical schemes that are assisted by the administrator. So there's another point that one wants to register, partly in relation to one of the points that was raised earlier in the course of the week. And the point that we want to get across is that there is certainly risk pooling. Now, in as far as the guaranteed risk benefits are concerned, what the Act allows is for medical schemes to optimize contracting, the use of networks, and the use of managed care organizations to really, as far as possible, manage the exposure to the fact that PMBs have to be, covered at cost. So there are limited options available to medical schemes to really manage the exposure to PMBs. And this is where the designated service providers also come in, Chair. It is something that is provided for, in the Act, and one would not argue that there's no room for improvement in how these are optimized, but their usefulness are there for the schemes to really be able to manage the exposure, in as far as PMBs are concerned, amongst other challenges that we face in the healthcare industry. So at the end of the day, the point that we want to leave with the panel with reference to this slide is that scheme trustees are really required to manage complex risk pools in the interests of all members. This becomes quite relevant in the context of the extent to which medical schemes are exposed to fraud, waste, and abuse, which presents a threat in as far as the funds and the limited resources that are available to cater for the healthcare needs that medical scheme members, pay for. Chair, moving on to further insights that we want to share with the panel in relation to medical scheme membership, amongst other considerations. Now, medical scheme membership is just under 9 million lives in the country, which is only around 16% of the South African population. Now, Chair, the HMI provisional report noted that this number has not been increasing as rapidly as the population over the last couple of years. The graph that we see on the screen shows that the percentage covered varies greatly by age, with a much greater proportion of older people being on schemes, and also female coverage in childbearing years being higher. Now, this in part, as it is indicated in the submission that we have made, demonstrates the concept of anti-selection, where people may sometimes join medical schemes at the time of need, and it does present a bit of a threat in as far as optimizing the risk pool is concerned. Now, what we want to stress in this regard is that it is important, that trustees protect the members' funds from fraud and abuse and make sure that they are used effectively and appropriately for paying for treatment that is needed, that is of high quality as well. I wish to reiterate, Chair, that the scheme do not have the data on racial profile of members, and the Health Market Inquiry also confirmed in their provisional report Now, CMS also does not have this information. The only source of data for the racial profile of medical scheme members that we are aware of comes from the General Household Survey published by Stats SA, which we have made reference to in our submission. And the latest report shows that 34% of medical scheme beneficiaries are white.
Mr. Mosembotane, just to ask a question about this. We hear the point that the schemes and administrators don't collect data or have data on race. But is that the only question that's relevant? Because thinking out aloud, it may be that their systems unintentionally draw distinctions on racial lines. Do you have any information on that?
Through the chair, we don't. We don't have information on that. This is why from this process, because through that we are currently not able to draw conclusions on. So the short answer to the question:
requested information from your members?
no, we haven't. I think in the wake of these allegations, there has obviously been a number of and we learned the process that would be an investment. So we have element of whether or not it for us from an perspective, but